In this case, let's understand the importance of converting a small tear in the posterior capsule into a stable opening, thereby preventing things from getting worse. Let's start with watching the surgery, where it was a planned stop and shop for a patient with a grade 2 nuclear sclerosis. We start with meticulous care while making the incisions, staining the capsule with blue dye, washing it out, introducing viscoelastic to flatten the anterior capsule, and then finally creating an optimally sized rhexis. Now, having completed the rhexis, we remove some viscoelastic from the anterior chamber and complete the hydrodissection. We are now ready to proceed with the nucleus management. The phaco probe is introduced into the eye and is rotated to a bevel up position. After the introduction of the Sinskey hook into the eye, the excess cortex overlying the nucleus is aspirated. We now start with sculpting the groove down the center of the nucleus. Half the tip needs to be buried each time you go across. Note how the probe and the groove are exactly in the same line. Also note how you require adequate exposure of the tip to reach the depth of the groove. Each time you move across, you find a progressive deepening of this groove until finally you have an evenly deep groove. In this case, having achieved that with the cross action of both instruments deep within the groove, the nucleus is divided. It is then rotated to get the heminucleus at right angles to the phaco probe. The dialer now replaced with the chopper, after which watch how we impale into this heminucleus and chop it into 2 smaller emulsifiable fragments. The other heminucleus is similarly broken down. Having broken down this nucleus into 4 emulsifiable fragments, turn by turn each fragment is brought out into the phaco safe zone, downsized further and emulsified. We watch the rest of the fragment emulsification and you will note that until now the entire surgery has remained uneventful. Watch how each fragment is brought to lie across the phaco probe, after which it is impaled, drawn up and emulsified. Having completed the nucleus emulsification, we now introduce some viscoelastic into the anterior chamber, and now we proceed with the bimanual irrigation aspiration. Bimanual irrigation aspiration allows for easy circumferential removal of the complete cortex. With the aspiration introduced to the right side, we remove the cortex from the inferior, superior and the left half of the eye. Having completed this, the instruments are withdrawn from the eye, after which the aspiration is now introduced from the left side and the left half of the cortex now removed. As we come towards the end of the cortex wash, let's see what happens. There's a little tag of cortex in the posterior capsule at the 10 o'clock position. I just go to gently aspirate it. Watch how I end up holding on to the posterior capsule. This is indicated by the star-shaped folds. Now, whenever you end up with a position where you end up holding on to the posterior capsule, always remember that when it is just sucked in, it will cause the folds. That doesn't necessarily mean that the capsule is already ruptured. At that point, a timely release of the reflux button should result in the release of the posterior capsule, which has been aspirated in the aspiration probe, resulting in saving the posterior capsule without creating a rend. It is equally important at this point to make sure that you don't accidentally pull the aspiration probe out of the eye, because pulling the aspiration probe would indeed result in the posterior capsule. Let's now see what happens in the rest of this case. I hit on the release button and get my instruments out of the eye. But unfortunately, as you can see now, I have actually created a D-shaped tear in the posterior capsule. Now, what's clearly obvious, it's not a round punched tear. A D-shaped tear, which means that you have a tearing edge which has a potential for extension. Now, the mistake I made here is assume that I could just go ahead because it was a tiny tear, put in viscoelastic and introduce the IOL. Indeed, I do take a lot of care and caution while introducing the single-piece monofocal IOL in the capsular bag in the presence of this mid-peripheral tear, and with care and caution, having introduced the entire IOL in the capsular bag, I ensure that I do not have any excessive movements or rotations of the IOL. But here's what I want you to notice. Having implanted the IOL, notice how the entire tear has extended to become an elliptical tear from the 10 to the 2 o'clock position across the posterior capsule. So now we are left with a large elliptical tear with an IOL in the capsular bag, but the haptics of the IOL are at right angles to this tear. The next step is performing a visco wash, wherein I remove the excess viscoelastic from the anterior chamber. I'm going to be extremely mindful that I do not press on the optic too much, thereby preventing any chance of a vitreous herniation. Finally, whilst maintaining the irrigation still in the eye, I hydrate both the left paracentesis as well as the main incision, and finally get the irrigation out of the eye. I then hydrate the right paracentesis incision. This, as you can see, is the end result that we achieved. I do hope you found this video tutorial useful. And I believe the biggest take-home message here is that when you have a partial opening in the posterior capsule, however big, it is extremely important to convert it into a stable round opening, which then allows for the safe placement of an IOL in the capsular bag with no risk of the PCR extending. I hope you found this video tutorial useful. Thank you.